Welcome to today's webinar. Before we get started today, I want to make a few brief announcements. We know many of you are listening in from far away and can't attend local events or programs. That's why we have a free webinar series. We host multiple webinars per month, so please visit our website to view the current schedule for 2018. Simply visit our website at www.johnson-center.org and click on the webinars link on the right-hand side. New webinars and events are often added, so if you are not on our email list, I encourage you to visit our website and click on the Join Our Email List link that appears on the homepage. To get instant news and events from the Johnson Center, follow us on Facebook, Instagram, and Twitter, as we often announce grant and scholarship opportunities, research opportunities, and special events and presentations there. And be sure to check out our YouTube channel at youtube.com/The Johnson Center. There you will find a library of several of our past presentations. We have many exciting programs still to come this summer, including our sibling camp, with grants and scholarships available for this program as well as for diagnostic services and counseling. This fall, we will continue our series of free workshops for parents with free childcare available, including another teddy bear clinic and a workshop on anxiety in children. Follow our Facebook, Twitter, or Instagram pages, or check into our website blog for more information. Be sure to follow our colleagues at the Autism Research Institute as they host their own webinar initiative, and they share some great resources on their website and social media pages. If you would like a certificate of attendance after today's webinar, look for a follow-up email in your mailbox 1 hour after the webinar concludes, or look for the link on our YouTube channel in the webinar description. It will contain instructions on how to get your certificate. If you have questions during the live webinar, you may type them into your GoToWebinar control panel. If you are watching a recording of this webinar, you may email questions to the presenter at info@johnson-center.org. Today's webinar was prepared by Tami. Amanda holds a master's degree in counseling psychology and has completed a recertification program in applied behavior analysis. In addition to being a board-certified behavior analyst, Amanda is also a licensed professional counselor. She has experience working with both children and adults, including those who have autism spectrum and other pervasive developmental disorders, ADD, ADHD, anxiety issues, and trauma, both as a BCBA and as a counselor. She has additional specialized training as a counselor in EMDR therapy and its applications to children. Amanda heads up the Johnson Center's Behavioral Services and Counseling programs and is a sought-after presenter. Please welcome Amanda.
Thank you, and thank you everyone for being here today as we talk about this important topic, depression in ASD, the signs, symptoms, and considerations for treatment. Before I get started, I want to note that there is not a lot of research on this topic. So some of the statistics around it and some of the information varies widely because the real numbers and the real accurate information is not yet known because so little research has been done on the topic. We hope that that will change in the future because this seems to be a very important and very popular topic, which to me and to us at the Johnson Center suggests that there is a need for the research and for more information to be out there on this topic. So hopefully more information will be to come, and we will continue to do additional webinars on the topic as more information becomes available. Or if you have questions that I don't cover in this webinar, I would love for you to send them in, and it will give us an idea of what kind of things we need to talk about in future webinars. So let's get started. I want to first provide some perspective from people with autism who struggle with depression. I have some quotes from different sources. The first one is from someone named Daniel, and this comes from an NPR National Public Radio story on mental health issues in people with autism. He says, people with autism aren't immediately born anxious or with depression. The world is fundamentally not built for us, and people are always judging and trying to change you, whether they have the best intentions or not. Of course, that's going to cause a higher rate of anxiety and depression and even suicide rates. I'd be surprised if it didn't. This one comes from a user in an online forum who says, because being different sucks and is stressful, because being held to a social standard that can't be met is stressful, because having to think over everything you want to say 3 or 4 times to make absolutely sure you won't offend anyone, and then offending someone anyway for completely opaque and unfathomable reasons is stressful. And finally, this is a description, again, from a user in an online forum of what it's like to experience depression. I've always felt an insanely strong suffering that came back every evening, every time I got alone. I just wanted to jump out of the window and stop existing, stop suffering. So in this webinar today, I'm going to talk about how we diagnose depression, the rates of depression, challenges to diagnosis in the ASD population, risk factors for depression, and treatment options. Again, I want to emphasize that what we know now is very limited. So there are still a lot of unknowns in this topic, and I'll discuss that specifically as we get to those points. So according to the DSM-5, which is the Diagnostic Manual for Psychiatric or Mental Health Conditions, depression is a persistent pattern of negative mood that lasts at least 2 weeks, causes significant impairment in functioning, and is not due to drug use, another mental health disorder, or bereavement. It's not due to death of a close loved one or some other event that we would expect would lead to feelings of low mood. Symptoms of depression in the DSM are low mood, low energy, anhedonia, which is loss of interest, so something that you previously really enjoyed doing or spent a lot of time doing is now no longer something that you want to do. Weight or appetite changes, that can be increase or decrease in weight or appetite. Sleep disturbance, changes in your sleep cycle. If you're someone who has always spent a lot of time sleeping or had trouble sleeping, that's not necessarily an indication of depression. But if we see some change in your sleep cycle or how much or how often you're sleeping, that can be an indication. Muscle movement changes, this can be agitation, someone who becomes really fidgety or seems like they have lots of energy in their body, or retardation, which means slowing down. You're no longer moving at the pace that you used to. And again, not due to some physical or physiological muscle change. Feelings of worthlessness or low self-esteem, the inability to think clearly or make decisions, recurring thoughts of death, dying, or suicide attempts and plans. When we're diagnosing depression, in general, these are the things that we're looking for. And a certain number of these symptoms is required for someone to meet criteria for a diagnosis. So how many people have depression? Well, let's look at the rates of mental health disorders in the general population compared to the autism population. According to the CDC, the general population has about 20% of people having some sort of mental health disorder, not just depression, but any mental health disorder. You'll see here that the autism population is about 60%. And this is one of those areas where the rates that we see varies very widely depending on the source. You might see some sources that say mental health disorders in the autism population is much less than that. Some say it's as high as 70 to 90%. So this is one of those areas where we just don't know what is the right number, what is the real rate. Depression in the general population is about 70%, and in the autism population, it is estimated at about 26%. I say estimated because, again, we really don't know, and we're going to talk about some of the reasons why we don't know how many people have depression, and there are major challenges in diagnosing it in just a minute. But regardless of the true number, you can see from these graphs that mental health disorders and depression specifically are occurring at much higher rates in the autism population than in the general population. Now, why is that? Why are the rates of mental health conditions so much higher in the autism population? Unfortunately, the answer is we don't know. We don't have the answer to that yet. There is limited research, and people are just now identifying the risk factors, and some even just now coming to understand that autism can exist, or that depression can exist in people with autism. So we have a long way to go in understanding why this is happening and what is different between the autism population and the general population as far as depression in our research. I'm sure that for those of you with autism who suffer from depression, you have a lot of information on this topic already, a lot to share. Some of the possible ideas that are out there are a possible genetic predisposition, that if someone has autism, they may be genetically predisposed or more likely to develop depression. The social isolation that might come with autism. We know that social isolation is a risk factor for depression in general, and people with autism are at higher risk for social isolation. So it might make sense that the social isolation contributes to the higher rates of depression. Could it be complications from medications? Many people with autism are on antidepressants or other psychiatric medications. Could that be contributing to the development of depression in this population? The multitude of sources of stress or life complications that a person with autism faces. I don't think it's a surprise that people with autism face a whole host of stressors that a neurotypical person does not, that the neurotypical person doesn't even notice or doesn't even think about, can be very stressful to someone with autism. And so might these life stressors, this high number or frequent encounter with lots of life stressors, contribute to the development of depression. Social comparison, or the comparison of oneself to other people in all areas of life. I think we saw from some of the quotes that I read at the beginning of this presentation that at least those few people who I quoted struggle with being seen as different, that they look at themselves in a way that, because of the messages that they get from other people, that they are not as good at various things, or that the things they are good at are not valued as highly as other things that they are not good at. They're constantly getting the message that they're not good enough, or that what they have to offer is not of value. So social comparison and this idea that I'm not as good as other people, maybe that contributes to the high rates of depression. And might it be because of some of the core features of autism? You know, some of the social communication challenges, or the rigid thought patterns. Might some of those core features be somehow related to the development of depression? We'll talk about a couple of those in our next section, which is challenges to diagnosing depression in the autism population. One of the reasons that the rate of occurrence of depression in people with autism is so highly variable depending on the source, and the reason that it's so hard to get an accurate number, is because diagnosing depression in the autism population is difficult. Let's talk about why. So first, there are communication challenges. So someone with autism may struggle to find the words or find a way to express what's happening within themselves. So that makes it less likely that that person is going to report those symptoms, or it may. Certainly every person with autism is different and has different challenges. So this may be true for some people with autism, but not everyone. So there are challenges in communicating and reporting your symptoms and the experiences. And if you're not able to report what's happening, either because you can't accurately describe it or because you don't try to in the first place, because having to do that creates its own anxiety or is really difficult, then you're not able to get help, you're not able to get that diagnosis. No one knows that that person is struggling with depression. So the communication challenges that can be a core feature of autism may contribute to the lack of diagnosis in some people. Let's talk about the symptoms of depression. I went over several of the DSM depression symptoms at the beginning of this presentation. Those were things like low mood, low energy, loss of interest, feelings of worthlessness, suicidal thoughts or plans or attempts, sleep disturbance, weight changes. And this is what we look for when we're diagnosing depression. These are the symptoms that say, if we have this many symptoms on this list, then this person meets criteria for depression. But in autism, the symptoms of depression may look very different. Someone with autism may have these symptoms or some of these symptoms. They absolutely might, and this might be what their depression looks like. But someone with autism may have symptoms of depression that look more like aggression or irritability or agitation. Labile moods, meaning mood swings from feeling neutral to feeling out of control or really high emotional state very quickly. Increase or decrease response to sensory stimuli. So whereas we're looking for things like changes in interest or changes in eating patterns for, in general, when we're diagnosing autism, for someone with autism, we may be needing to look at other things like how are responses to sensory stimuli changing, or how are we seeing any changes in repetitive behaviors. So the set of criteria that we're using to diagnose depression may not capture depression as well in the autism population. On top of that, some of the symptoms or some of the symptoms of depression are also common in autism. So autism symptoms may be masking signs of depression. If we just assume that some of these things are because the person has autism, then we're less likely to look at them as a symptom of depression. For example, sleep disturbance. Different sleep patterns can be very common in the autism population, can also be common in depression. So if we are looking at a person with autism and saying they're having sleep disturbance, they're reporting changes in sleep patterns, sleep cycles. If I attribute that to autism rather than a possible sign of depression, then I may be missing depression in a lot of people. Flat affect, which refers to the showing little emotion through your body language and your tone of voice. That doesn't mean that you're not feeling the emotion, but you're showing little emotion, which again can be a sign of both depression and can be common in autism. Trouble concentrating, social withdrawal, lack of eye contact, all of these things can be signs of depression, but they are also things that are common in people with autism. So because because the same symptoms are present in both conditions, if we are attributing all of those conditions to autism, then we're misdiagnosing a lot of people with depression. We're missing those diagnoses. There may be many more people with autism who have depression, but their symptoms are being masked. On the other hand, it's also possible that we're overdiagnosing depression. That if we're seeing all of these symptoms and saying, oh, they have enough of these symptoms that they would qualify for a depression diagnosis. Maybe that's an overdiagnosis of depression in people with autism, but we don't know. We don't know the answer to that because there are not a lot of effective depression assessment measures for the autism population. All of the existing depression assessment measures are based on depression diagnostic criteria outlined in the DSM-5, I'm sorry. And as we just discussed, those symptoms that are outlined in the DSM may not accurately reflect autism symptoms, depression symptoms in people with autism. So if we're basing the depression assessments on a set of criteria that doesn't match what depression looks like in this group of people, these assessment measures are not going to give us accurate information. All of the existing depression inventories have been validated in the general population. They have not been validated for the autism population. So again, we don't know that those assessment measures, if given to someone with autism, tells us what we think is telling us. There are no diagnostic assessments that have been validated for people with autism, none. And higher baseline scores of depression symptoms on all of the assessments for people with autism might suggest both an over or an underdiagnosis of depression and ASD. So when someone with ASD is given these existing depression assessments that have not been validated for the autism population, what we tend to see is that they tend to score higher on all of the symptoms or many of the symptoms of depression. Baseline meaning their scores before treatment. Now, does this mean that that people with autism are experiencing higher rates of depression or more severe, more intense depression? We don't know, because we don't know that the measures are accurate. We don't know that the assessments are getting the information that we are looking for this population, because none of it has been studied, none of it has been validated with this population. So there's so much that's unknown about diagnosing it and the measures that we're using to diagnose it in people with autism. So in addition to the criteria and the measures that are used to diagnose depression, there are some other factors that go into the challenges in diagnosing depression in people with autism. One is emotion regulation. Emotion regulation is a developmental capacity of individuals to monitor, evaluate, and importantly, modify their emotional state and arousal level to maintain engagement and accomplish objectives. So we change our emotional state in order to meet some long-term goal. If we are in line at the grocery store and the person in front of us is taking a really long time, we might get really angry. We might get very frustrated because it is taking much longer than this should take. But what do? What is the emotional response that we give when we're in this line that's taking forever at the grocery store? A sigh or something like that, maybe an eye roll. It is not yelling at that person or running your shopping cart into them. We regulate our emotion, so we change the emotional intensity that we're experiencing in order to meet a long-term goal. I want to get out of the grocery store with all of the groceries that I am in line to buy. I don't want to get kicked out. I don't want to get in a fight with someone. So I change the emotional intensity that I'm experiencing in order to meet that goal. There is growing research, but again, this is an area with pretty limited research. But what is out there shows that people with autism tend to have difficulty regulating their emotional experiences, and especially modifying their emotional experiences. The tools, the strategies that we use to modify modify our emotions depends on the situation. Some strategies might work better in certain circumstances than others. It is people with autism often use less effective strategies. So the strategies, if they are able to recognize that they need to modify their emotional experience, they often choose strategies that don't work or that are not right for that situation. But the strategies that will work are context dependent. So in some contexts, that strategy might work, but in others it doesn't. But because finding the right strategy requires flexibility, cognitive flexibility, and the ability to recognize when it's not working and try something else, for someone with autism who may have more rigid patterns of thinking, it's much more difficult to identify that and switch to something else, to something that will work better. So people with autism may struggle with regulating their emotions, and this can look like, going from 0 to 10 or having a really big reaction. And as I said earlier, labile emotions, or that going from 0 to 10 emotionally can be an indication of depression. But if we're looking at that as poor emotion regulation, which it very well may be, but if we're only looking at it through that lens, that is what it is, we may be missing it as a possible sign of depression. Let's talk about affect versus mood. Affect is what we show emotionally on the outside. We show our emotions through our facial expressions, our body posture, our tone of voice, the words we use. Mood is what's happening on the inside. Mood is how we're feeling inside. It's possible to feel one way on the inside and show something else on the outside. Sometimes they match and sometimes they don't. Someone with autism may have flat affect, which is showing little emotion through our body language and facial expression and and tone of voice. They're not showing a lot of emotion that way. That may be an indication of depression, which may be missed because we're attributing it to autism. But it also may create a challenge in diagnosing depression in another way. That if someone is not showing emotion on the outside, then other people don't know how they're feeling. And so if someone is feeling depressed, if someone is having the low mood and low energy and having these indications of depression, but they aren't showing that they're sad, or they're not feeling that they're not showing that they're feeling down. If they don't have the verbal ability to communicate that they're feeling that way, or if they don't have the emotional awareness to communicate that they're feeling that way, other people aren't able to see those signals either. If someone is crying frequently, or if someone is, just has a down demeanor that is different from their usual demeanor, other people might be able to say, I think something's up, something doesn't seem right. But if someone has flat affect and is not able to show how they're feeling, is not able to show that they're sad, or doesn't show that they're sad, then other people are also not getting those signals and are not able to intervene. Rumination is really common in depression. Rumination is thinking about something over and over, especially something that was hurtful, something that was negative in some way, something that you screwed up, something that someone else did that made you feel bad, or made you, your response to it was a feeling of worthlessness, or not being good enough. And rumination is common in depression. It is a sign that we look for. It's not one of the symptoms listed in the DSM, but it is a sign that to a clinician who's diagnosing, they might look at that as a possible red flag. People with autism may have a tendency to ruminate, but because they have autism, we may attribute it to perseveration, or we may attribute it to it's a repetitive behavior. They're repeating this bad thing that they heard, or this thing that felt bad, because they repeat things. It's a repetitive behavior. We may miss it as rumination, because again, we attribute it to it's autism, it's perseveration. This is just a repetitive behavior, but really it's having a psychological, it may be doing psychological damage, or be hurtful to the person, and that's why they are repeating it over and over. They can't stop thinking about it because it was hurtful, or it made them feel really bad. Alexithymia is the inability for a person to recognize and identify their own feelings. So a person with alexithymia is sad, or is getting angry, or whatever. It can be happy stuff too. They're happy, or they're excited, but they don't recognize those feelings within themselves. So they're getting mad, or they're feeling sad, but they don't recognize that they're feeling that way, so they can't do anything to regulate. They can't modify those emotions because they don't recognize them. So, and alexithymia is common in people with autism. So I'm sure you can imagine that if someone is not aware, or someone can't recognize their emotional experience, they may have a hard time identifying that they're feeling depressed, or they may have a hard time identifying that their mood has been really low for a really long time, and this doesn't feel good. This isn't normal for me. So alexithymia can be a barrier to reporting one's own experience, your own symptoms of depression. If we don't realize that we're having these symptoms, we can't report them. But it's also in the assessment measures. If the assessment measures are asking, from 0 to 10, what's your mood been? If someone can't identify their emotions, or describe what their mood feels like, they're not going to be able to answer questions like that. Okay, so let's move on to some risk factors for depression. In autism, many of the risk factors that are known are similar to those in the general population. Again, as I said before, I want to emphasize there's not much research on this. So there are probably other risk factors for someone with autism to develop depression that we do not know. We don't have the information yet. Probably some of you who are out there listening who have autism, you probably know what might have contributed to you developing autism, or what were some of the signs that people may have missed, or maybe you didn't have that experience of not being diagnosed when you should have. And you probably have answers that the research community does not have yet. But what we do know is that a family history of depression can be a risk factor. That if you have close family members who have depression or even bipolar disorder, you're more likely to suffer from depression. Traumatic experiences can, I just noticed that my arrows on this graphic are going in different directions. I'll have to fix that. Traumatic experiences can contribute. Many people report that, and this is not for people with autism, this is in the general population. Many people report that depression symptoms started after some traumatic event, and a history of trauma does make someone more, put someone more at risk for developing depression. The onset of puberty. At the onset of puberty, we see a lot of, and again, general population, but this also applies to people with autism, we see the rate of depression go up. So kids are less likely to meet criteria for depression. Once someone hits puberty, that rate tends to go up. Being the victim of bullying. People who experience bullying report higher rates of depression. And unfortunately, we know that the population of people with autism experience bullying at higher rates, which puts them as a population at greater risk for depression. People with high functioning autism tend to be at greater risk of developing depression than people who have greater impairments, greater symptoms of autism. But again, I want to be clear that this may be because we don't know how to measure depression in people with greater impairments or people with autism who have more severe symptoms. And people who are in environments with little structure. People with autism tend to report less depression when they're in some sort of environment or in their daily life, they have a lot of structured activities. And again, so much about this is still unknown. So how do we treat depression in people with autism? So in the general population, medication and talk therapy are the two types of treatment for autism. And the same is true, for depression. And the same is true for people with autism. People with autism have the same options for treatment, medication or talk therapy. And research shows that a combination of both of those things for the general population is the most effective treatment. Unfortunately, there have been very few studies, possibly none. I'm not sure if there have been any studies looking at medication and talk therapy combined as a treatment for depression in people with autism. So while we know that this is the most effective treatment for the general population, we don't have research to show that, excuse me, that this is also the most effective treatment for people with autism and depression. We do have studies looking at both separately, at treating depression through medication and treating depression through talk therapy. So in talk therapy, there are several types of therapy that have been studied that show that talk therapy can be effective. Cognitive behavioral therapy is the most well-researched study. There's actually much more research on anxiety in autism and cognitive behavioral therapy than there is for depression, but there is some for depression that shows that cognitive behavioral therapy is an effective treatment option. Applied behavior analysis, or ABA, can actually be used to treat depression. And for some for whom talk therapy is, just not for them, that have to go and talk to someone about their depression or talk to someone about what's going on with them, talking can be really difficult for someone with social and communication challenges. So in that case, applied behavior analysis can actually be an effective intervention for depression. Acceptance and commitment therapy is also an intervention that has been shown to be effective for people with autism, for depression, as well as many other conditions. And acceptance and commitment therapy was actually developed by psychologists and board-certified behavior analysts to deal with internal events that preceded behaviors. So it has kind of an ABA backbone to it, and there's a lot of research that shows that it has been effective in treating people with autism. Mindfulness is another talk therapy approach that has growing research, a growing body of research, not as much as CBT, but there's a lot of research coming out that shows that mindfulness therapy can also be effective in treating depression in people with autism, and in some cases can be even more effective, it's believed, because in cognitive behavioral therapy, many of the interventions are centered around changing your thoughts. If I think about the situation in a different way, or if I identify what's making me so anxious and can use cognitive restructuring to think about it differently, then I won't have such an emotional reaction to it, or my emotional response will improve. But if someone's emotional level is already to the point that they're not able to think clearly, or that changing, to think about it differently might not decrease the emotional intensity that they're experiencing, mindfulness focuses more on being able to tolerate the emotion, to just notice what's happening and know that I'll be okay, that this too will pass. And so mindfulness techniques, mindfulness interventions, have in some studies shown to be even more effective than CBT, possibly for that reason, because they're not so focused on the thoughts that might be inaccessible, or if someone's not able to think clearly, changing thoughts isn't going to help that much. But again, there's much more limited research on mindfulness than there is on cognitive behavioral therapy. And there are lots of other techniques in talk therapy that may be effective. Unfortunately, many people find that there are not a lot of therapists, not a lot of counselors who are familiar with or who have experience in working with people with autism. And using some of these types of therapy that are listed here in someone with autism may look a little different than if you're using it with someone without autism. Someone with autism may need much more repetition in an intervention or a coping strategy. Someone with autism may need more time, more opportunity to talk through the problem or be with a therapist or practice the intervention with a therapist. They may need different types of coping tools. They may need more sensory-based coping tools than the cognitive restructuring ones that we may be most used to. So there are a lot of challenges in getting people with autism talk therapy because there are not a lot of therapists who know how to modify the interventions for them, or who have the experience with autism to know that these may be signs of depression and not just autism. And medication is also a possible treatment for depression. There is, so because there are so few, gosh, I'm so sorry. Because there are so few therapists who are able to provide talk therapy to people with autism, medication is often the first path for treatment. Possible types of medication that may be prescribed are antidepressants, antipsychotics, and benzodiazepines. Benzodiazepines more so for anxiety than for depression. And antipsychotics, I don't want that name to scare anyone. That is just a class of drug. Often antipsychotics, drugs from that class of drug are used alongside antidepressants. So someone would be prescribed both an antidepressant and an antipsychotic, and the antipsychotic augments the effects of the antidepressants and maybe makes them more effective. Now, a lot of people with autism are already on some types of medication. A lot of people with autism are already on some type of antidepressant, and that can make it difficult to know, what are the effects of, and not for depression, but they're on antidepressants or other of these medications for complications or challenges they have because of autism. And so that makes it difficult to know, what would have been the effect of this antidepressant on the depression if they weren't already on it before we started it for the depression. Or might the side effects of the medications be contributing to the onset of depression? Again, in this area, there is so much that we don't know. But like I said, medication is often the first line of defense, or the first type of treatment that people with autism may be given, because it's what they have access to when they may not have access to talk therapy. Okay, I have just a few minutes. I can answer some questions. So if you'll give me a couple of minutes while I pull them up, and I will be right back. Okay, so my first question, what would be some effective strategies for helping an individual through rumination so that they can process the emotions that they may be feeling and recover? So that's a good question. So for some, it may be helpful to teach them what rumination is, be able to identify when they're doing it, and give them a time limit. For 5 minutes, you can think about this problem. You can think about what happened. And after 5 minutes, it is not, it's not helping you anymore. So then it's time to move on. And you may even teach them to set a timer, or if they don't need that, teach them that this is what rumination is. And if it's happening for too long, it's not helping you, it's hurting you. And they may be able to do that and then move on. For others, even if you tell them, okay, you've been thinking about this for 5 minutes, it's time to think about something else, they can't just turn it off. They can't just say, okay, I'm not going to think about it anymore. And so rumination is really, from my perspective at least, rumination is an indication of some anxiety, that this is disturbing and now I can't stop thinking about it. So giving that person, finding what works for that person for calming their anxiety and encouraging them to do that when they're ruminating is maybe what they need. So let's say someone is, coming to you asking for reassurance over and over and over. Like I said, that may be a repetitive behavior, but it also may be an indication that they're ruminating on this topic. And so instead of, and you can give them the same response over and over and over, but that's not helping. To me, that's an indication that maybe there is some anxiety, that they're anxious about this for whatever reason. So help them get out of the mindset of problem solving. Don't focus on giving them the answer anymore or finding a solution for the problem. Turn instead to ways that you can help them cope with the anxiety, whether that's sensory tools or maybe they're able to think about the problem in a different way if they're cognitively able to, or just being there in that moment and say, I can see that this is really bothering you. What's the worst part about it? And hear them, let them know that you're there with them. You can get mad with them, be there emotionally with them, join with them, and show them that you get it. This is not fun. This feels really bad. And use those tools that you may know of, or work to find tools that help the person calm down from a state of anxiety, and use that when they're ruminating. Has the risk of suicide been studied in children who take antidepressants to treat depression? There are studies looking at the risk of suicide in children taking antidepressants. I don't know the statistics off the top of my head, but there are studies. I don't believe, and I could be wrong about this, I don't believe that there are studies on the autism population specifically. There are studies on children in general, but I'm not aware of any that are on children with autism. I could be wrong about that. I haven't looked into that specifically, but as far to my knowledge, there are not any, and I don't know the statistics on the rate of suicide in children taking antidepressants in general. Okay, a couple people are asking about access to the slides and how to get this information later. So we do not send out the copies of the slides, but you can access this webinar again on our YouTube channel. To access it on our YouTube channel, actually, let me go to the next slide where I think it is written. Yes. youtube.com/user/the Johnson Center. You can find this as well as all of our other webinars on that YouTube channel. Once you are to the Johnson Center's page, there's a search bar and you can type in whatever topic you're looking for. And our most recent ones are always, at least I believe, the most recent ones are always on the page where when the page first comes up, you can see all of the most recent webinars there. So this webinar will be up there within the next couple of days. And if you go to the Johnson Center's YouTube channel, it should be right there that you can listen to the recording. Okay, I have just about a minute left. And someone asked, can you describe the differences among CBT, mindfulness, and ACT therapies again? So each of these is really just a different approach to talk therapy. The interventions that they're going to use will be different, and it's all based on the therapist's training and how they conceptualize the problem. Cognitive behavioral therapy involves a lot of changing of our thoughts. The idea being that if we change thoughts, the way we feel will change and the way we act will change. But some CBT interventions can also target the emotions or the behavior specifically. But most of the interventions, at least as far as I'm aware, involve what's called cognitive restructure. Gosh, I'm so sorry. Cognitive restructuring, in which you learn to think of the problem in a different way. You identify in what way you're thinking about the problem that's not effective or that's causing all this anxiety or causing this depression, and then you learn to identify when that thought pattern is happening, and when it's happening, you learn how to think about it in a different way. So you recognize that I am thinking that the worst thing possible is going to happen, and I know that that's not true. So I need to remind myself that I'm catastrophizing and that this isn't, that good things are going to happen. In mindfulness-based therapy, the person learns to be present in the moment right now, that instead of worrying about all the things that are going to happen or stressing about the things that happened in the past, they learn to be present in the here and now. And in doing so, they learn to tolerate the emotional experience that they're having. They learn to accept that, their thoughts are not necessarily true, or that their thoughts don't have to define them. And, whatever happens in their mind in the here and now, they can just notice it and let it go. None of it has to be permanent. None of it has to define them. And in acceptance and commitment therapy, it's also lots of accepting of the present state, accepting of emotions, but also in acceptance and commitment therapy, you are identifying core values that are most important to you as an individual or to your family, and from there identify, the idea being that when you're not working in alignment with your core values, it causes this distress and causes the unpleasant emotions. And so if we find ways to get back in line, to act in line with those core values, then we can improve our emotional experience. And I am at time, so please, check out our YouTube channel. We're also on Facebook and Twitter and Instagram. Sign up for our email notifications to get notifications about upcoming webinars. And for more information, feel free to contact us at the Johnson Center about our services, or for more information on depression and autism. I also want to mention that there is a webinar on the YouTube channel about the use of mindfulness in people with autism. So check that out. And thank you so much for being here today. Again, a very important topic, and I hope that in the future we can have another webinar and I can give you even more information about it. Thanks so much. Have a great day, everyone.